Okay, so today's topic we're starting with is clinical mechanisms for unresponsive and chronic gastrointestinal disorders. So one of the things that you have to understand working with GI conditions and working with chronic patients, if you haven't been exposed to a lot of them, is there are some people who are not going to respond. The key thing is you need to know who they are before you start, because if you don't, that's basically clinical naiveness. You don't want clinical naiveness. You want to go into a clinical situation and talk to the patient and have a general good idea of what's expected and what's going to happen and what's not going to happen. And if you don't have that understanding, and if you have that naiveness, basically what happens is your patient will lose trust with you. Do you understand? So there are some conditions that are uncurable. You guys, autoimmunity is uncurable. If you're curing autoimmune disease, you don't know what you're doing. You don't understand immunology. You think remission is cure. You don't understand the nature of it. If you are curing autoimmune disease, you should win the Nobel Prize in medicine. Please let us know. Okay? So if you're reversing celiac disease and not getting any gluten because of something you did, you should win a Nobel Prize in medicine. You guys don't, so what we see is people that don't understand autoimmunity, they don't understand the biomarkers, they don't test, they see a patient feeling better and they go, I cured it, I'm awesome. You're like, no, you really are not. You're actually opposite, because you don't even understand, you don't know what you're talking about, okay? So there's some frustration, sorry, that came out. Okay. So, but in reality, we have to know what we're dealing with, because the patient's suffering. The patient, patients are scared. Patients, by the time you have an unresponsive chronic patient come see you, they don't trust healthcare practitioners. They'll be nice to you and they'll smile, but how many other people did they go to that said, I'm gonna fix you. I know what this is. This is Candida syndrome. This is heavy metal, this is that. And it's not any of those things. So I think one of the things it's really important to talk as its own special topic are these unresponsive or let's say like ongoing conditions that are just part of disease processes, right? So let's go through those. And with them, it's not like you can't do things to help improve the quality of life, because you absolutely can. It's just that it has to be an ongoing process. And the patient will know, like if they don't follow certain dietary guidelines and change some lifestyle issues and maybe even support themselves with various supplements, they're not going to function as well. And the minute they stop doing that, they'll feel it. And then when they go back on, they'll feel better. And it'll just be an ongoing thing. And that's the typical response you see with these unresponsive patients, okay? So the first part of today is just to go over these clinical mechanisms. And the key thing about these unresponsive patients also is that if you can improve the quality of their life, I mean, they are very grateful. And many of these mechanisms, if you improve their expression, then they don't progress to further disease, because these are difficult issues to deal with, okay? Now, so the academic goal is to understand the pathophysiology of chronic unresponsive GI conditions, and the clinical is how to identify them in practice and what to do with them when you see them, how to follow them up, what kind of treatment regimen would you give them, but you're not expecting big change as far as, let's say, reversal. Okay, you're just expecting improved quality of life and improved function. So this is one of the first diagrams I showed you. So if a patient comes in with chief complaints of bloating, constipation, increased reactions to foods, and fatigue and depression, and let's say we just talked about the increased food reactions, we went through a list and said, okay, well, if they have reactions to food, it's just a digestive enzyme issue, easy, right? Just hypochlorite, hydrochloric acid, fix the gallbladder, easy stuff, no big deal. Then they have intestinal permeability. Some of those can be complex, but that's not, a lot of those you can change pretty quickly, and that's great. And then you have loss of oral tolerance, which is more progressed. And then you could have a person come in and they have reactions to foods, but they have intestinal autoimmunity, and that's a whole different ballgame. Okay, that's the point where your immune system is now attacking their own body, attacking their own tissue. So you want to make sure you know how to find it. So the first way to find these unresponsive chronic conditions like autoimmunity, intestinal autoimmunity, for example, by the way, the main unresponsive ones are intestinal autoimmunity. That includes celiac disease, ulcerative colitis, Crohn's, autoimmune gastritis. Those are all part of the autoimmunities of the gut. You have to figure out dysautonomias. I'll show you how to figure out those. And the neurodegenerative disorders that impact the gut, and early Parkinson's disease, and any kind of metabolic disease that's impacting perfusion to the gut. Those are the main categories. If you can pick up those, you're going to find these unresponsive ones. You still have to do things to improve their GI tract and quality of life, but your prognosis is poor. Like, what's going to happen with their care? So when you're looking at the 3 most important clinical questions, how's their diet? Most of the people that have unresponsive issues, they come in, their diet's impeccable. And it's not because of choice, it's because they have to do it. They'll just say, I cannot function if I eat this food. I cannot function if I do that. I have to make my own food. I have to cook my own things. There's no way. Whenever you hear that, it should be like, red flag, ding, ding, ding. Is this one of these unresponsive cases? So that will be one of the first key features about their diet, okay? For the most part, by the time they come see you as a healthcare professional in like a private practice setting. How long have they had their condition? So people with these unresponsive, it's going to be definitely more than 1 year. It's going to be, many, many years that they've had these, struggled with it, constantly going from one person to the next, trying new things, trying various supplements. That's another red flag for you. It's one of these unresponsive types of patterns. And then has anything helped? The big giveaway is no. Or some things have sometimes helped. And if anything, with these unresponsive ones, the things that have really helped, you'll find, is like they get off inflammatory foods. That makes a big difference for them at some point. Most common inflammatory foods being, again, gluten, casein, egg albumin, soy, corn. Those are the most common inflammatory foods that people that have inflammatory conditions feel better when they come off. But it doesn't change their condition. They just feel some improvements with it. And some will notice they'll have, if they take an anti-inflammatory supplement, it'll help them. But even though things that help them, it doesn't change their condition. That's the key thing. So if you see a patient come in that's eating a diet because they have to, that is very restricted, not because of health reasons or by choice, but they have to do it. And you see someone who's had a condition ongoing for many years with a huge list of practitioners, and you see they're taking lots of stuff, and nothing really changes their condition. Some things maybe help them. Anti-inflammatory diets may have made a difference for them. You're now starting to think this person may have an unresponsive condition. Does that make sense? You definitely don't want to think, I just think you have leaky gut. If I give you some glutamine and and some more things, you're going to get better. That is not the way to think. It's like, hey, let's really find out what the cause of it is. Now, the minute you see that they have unresponsive condition, you have to immediately start screening for malabsorption syndromes. We're going to get into malabsorption syndromes after this talk, which is how to evaluate a GI patient. But the key thing with unresponsive patients is that they can actually destroy their gut lining and their microvilli, and they can get into a malabsorption syndrome pattern. Okay? So again, this is where the ball game starts to change, where you're dealing with more of a chronic condition. Okay. So here's the list of the most common unresponsive GI issues. And I want to go through these one by one. And let's start with celiac disease. So there's a big difference between celiac disease and gluten sensitivity. Okay? Celiac disease is really an autoimmunity. Don't even think about gluten. It's an autoimmunity against transglutaminase 2. Think of it that way. Gluten is just one of the triggers, but it's actually an intestinal autoimmunity, and the target protein transglutaminase 2 is found in the intestines. And once someone develops autoimmunity, they don't need any other triggers that trigger their immune response can flare them up. Now, gluten has been the key protein target trigger for celiac disease, but foods that are similar to it can trigger it. If someone has chemical exposure, someone has fatigue and stress, all those things that normally trigger immune responses, they can get an infection like the common flu and then have their autoimmunity flare up. That still happens unrelated to gluten exposure if people have celiac. So don't think of celiac disease as a gluten issue. Think of it more as a transglutaminase 2 autoimmunity. And then I think it's easier to see all the different triggers for it. It's not just gluten. But gluten removal is critical for them because it is a very aggressive trigger for them. Now, the key thing with celiac disease versus gluten sensitivity is that celiac disease has a specific genotype. On an antigen-presenting cells, you have what are called human leukocyte antigen gene types, okay? HLA-Q gene types, and they have an HLA-G type 2 and 8. And we're going to get into all this in much more detail with different autoimmune diseases next module, okay? But for now, just know that they have an HLA-DQ 2 and 8. And what that means is that when their dendritic cells sample gluten, they have a very, very aggressive response with cytotoxic T cells in their gut that is very unique to that disease process, and it aggressively destroys the gut. That gene type with HLA-DQ2 and 8 and gluten exposure is unique to celiac and not associated with gluten sensitivity. Gluten sensitivity causes inflammation, all types of things, but it doesn't cause that significant HLA-DQ2 and 8 T cell activation, which destroys the gut. And you can actually get villous atrophy, and you get malabsorption syndromes. And yes, you could actually die from celiac disease if it continues on. I mean, it's not the same thing as gluten sensitivity, okay? And this is why it's important sometimes to test, because you're not looking for, well, they're going to be off gluten anyways. You want to go, do they have an autoimmunity against transglutaminase 2? Because it's a whole different scenario, okay? Now, we know that celiac disease is largely still undiagnosed. For every symptomatic patient with celiac disease, there are 8 patients with celiac disease and no gastrointestinal symptoms. That's another key thing. So the majority of patients that actually have transglutaminase 2 don't actually have GI symptoms. They just have chronic inflammation. Or they just come in with a malabsorption syndrome. Okay? So if you're looking for chronic GI symptoms, you're going to miss most of them. And actually, the most common area of celiac destruction is actually the brain. And there's also another enzyme called transglutaminase 6, which also is activated by HLA-DQ2 and 8, and it causes the brain to degenerate, specifically the cerebellum. And this is known as gluten ataxia. I'm going to show you a cool case with gluten ataxia next module. I mean, it's mind-blowing. Okay? But it is a very destructive response. And in some of the neurology literature, they're saying, you know, most of the people that actually have celiac end up having brain degeneration way before they have any gut symptoms. And really, it's really a neurological disease. It just happened that the gastroenterologist found it first. Okay. So when you get this aggressive gluten, when you get this transglutaminase response, either 2 for celiac, 6 which is associated with brain, then you can get some significant problems. Okay. Now the current ratio of clinical diagnosed to undetected cases is the size of an iceberg. They say like 1 to 8. This was a paper that was published, and they just said like most of these people don't get diagnosed. Okay. So do we have an explosion of celiac disease? What happened? Is it more popular? Maybe. The genotype HLA-DQ2 and 8 occurs in about a third of the population. Just because you have the genotype doesn't mean you turn into having celiac disease. It just means you have susceptibility for the disease, right? So if we have a third of the US population that has an HLA-DQ2-8 genotype of one variant or another of the 2 or 8, and you know, we have, let's say, about, currently they say it's about 3% of the population, which is considered undiagnosed, like many people have not been diagnosed, but let's say it's higher. Let's say it's around 5% or something like that. These people that have these genetic susceptibility, what has turned it on? Because the rates of celiac disease have gone up, even when they do studies to account for the trend in diagnosis. So there's different theories about that. One of them is there's new wheat that is the trigger. So it's genes plus environment, right? So we know that gluten is not genetically modified, but gluten is hybridized. And in the immunological literature, they call our wheat modern wheat, because the hybridization has created new wheat proteins. This is not through genetic modification, this is through hybridization. And there's other people that have said, well, it's not just that also, it's that we have now pesticides that bind to gluten and they change the protein structure. So when you have a protein, the shape of it allows different immune cells to respond or not respond to it, because the shape of it determines which amino acid sequences are sticking out for immune responses, right? So chemicals can bind to proteins and they can change the shape. And when they change the shape, they can become new antigens. Okay? That was what my PhD work was all of that. And then when they change the antigen, they become new proteins, new triggers. So the combination of hybridization with new wheat proteins that have been identified with about a 3 to 5% change, and the potential for certain chemicals like pesticides to bind to them, one of the theories out there is that, yeah, these susceptible HLA-DQ2 and 8 has always been around, but now it's really turning on because one of the triggers is potentially new wheat, in addition to autoimmune disease exploding all over the world because of just industrialization and chemical exposures and microbiomes shrinking and all the other stuff. Okay? So that's the key thing. Now, so this is just a diagram showing like native gluten protein, gluten deamidation, hybridization, and then you get gluten proteomes. And for people that have not gluten celiac disease, but people that have gluten sensitivity, you know, when they go to Europe, they feel much better because they're using native wheat there, especially in areas like France, because they don't allow new wheat. Okay? And then Europeans, I was just in Europe, I was talking to some people there, they're like, oh, when we come to the US, we go gluten-free. If we don't, we feel really sick. Okay? And that's gluten sensitivity. People that have celiac, they can't eat gluten in Europe, they can't eat gluten here, it doesn't matter. Those, you know, so just so you know. Like if you have actual celiac, it doesn't matter if you go to the middle of France and get a baguette from 500-year-old grain. It's going to cause a reaction. But gluten sensitivity people can tolerate different, you know, older grains with as much reaction. And what they found is that these new gluten proteomes, they activate transglutaminase, cause intestinal permeability, but they also cross-react with cell tissues throughout the body. And this is where you can get a lot of autoimmune responses. And research shows even minute traces of gliadin are capable of triggering a state of heightened immune response in gluten-sensitive people, HLA-DQ2 and 8. You just need a little bit. You just need a bite. So there's always the saying, like, you either are gluten-free or you're not gluten-free, just like you're either pregnant or you're not pregnant. Okay? Are you pregnant? Kinda. I think so. I don't know. Well, I try. I'm almost pregnant. I'm almost pregnant. Like, I don't check when they tell me there's gluten in there. I just kind of, you know, just don't eat bread. That's not gluten-free. Like, if you're gluten-free, you don't eat sauces at a restaurant, you're not sure what's in it, you're very careful what you eat, and it's a very conscious effort. It's not just like you don't eat bread, okay? Now, the key thing with celiac disease, for the world of autoimmunity, it's awesome to study because they know the three key things you need to know for an autoimmune disease. What's the trigger, what's the genotype, and what's the target autoimmune protein? And they know those. They don't know those for most autoimmune diseases. Like if you look at psoriasis or arthritis, they don't know this. They don't really know what some of these mechanisms are. We don't know what the triggers are for psoriatic arthritis in this clear of a sense. With celiac disease, they know you put gluten exposure with this genotype and this expression of this antibody, and boom, you can see it right there. Okay, so this is what's great. So this is why a lot of people study celiac disease in the autoimmune world. So we know that the trigger is gluten. We know they make gluten antibodies. The genotype is HLA-DQ2 and 8, and the target antibody is transglutaminase 2. And they know with histology that they're going to get intestinal. They're going to get biopsy changes, villus atrophy, crypt hyperplasia, intraepithelial lymphocytes, and it's going to be resolved with gluten removal. Those are the key things. So that's very important. Now that is different than gluten sensitivity. Gluten sensitivity is HLA-DQ1 and 4. You can get some inflammation throughout the body. You can definitely get leaky gut. You can definitely promote autoimmunity with it. Gliadin antibodies alone can cross-react with other tissue proteins throughout the body, many of them. So it's a major trigger for autoimmunity in general, but it's not going to cause malabsorption syndrome and complete villus atrophy. Do you guys understand? Okay, so the transglutaminase 2 characteristic is it really makes it so different. And the genotype that activates the T cells very aggressively. So if you see an HLA-DQ1 and 4, you're not going to get, for example, you'd have gluten sensitivity, but you're not going to get that aggressive T cell response that you would if you had a 2 and 8 response. So that's why it's good to know what degree of gluten sensitivity they have, or I even think about gluten sensitivity. Do they actually have transglutaminase 2 or 6 autoimmunity? Okay. So when you look at exposure to gluten, though, for the most part, and we talk about the celiac type, HLA-DQ8 with enteropathy, HLA-DQ2 and 8 is there, they get celiac disease. And then the other key thing is there's a lot of debate in the celiac and immune community because they go, maybe 2 and 8 are not the only ones. There are other genotypes too, because they're seeing the same characteristic changes of villus atrophy with other genotypes. But for sure, they know if you have 2 and 8 together, you're at significant risk for a hyperactive T cell response. But there could be other genotypes that they're still evaluating. Okay, and then we also know without enteropathy, it gets tissue inflammation and gluteomorphin reactions. Gluten can react an opioid type substance called gluteomorphin, and that causes neurochemical imbalances. And when people have celiac and significant gluten sensitivity, when they go off gluten, they can get what's called a gluteomorphin withdrawal syndrome, where they actually feel worse going off it. They get like mood changes, they get like diarrhea, they get GI hyperactivity, cramping, pain for a few days, and then they're fine. And those patients will typically say, I felt better eating gluten than I did without it. I never felt this bad. That's theorized to be a gluteomorphin withdrawal syndrome. And then people who make antibodies to gluten, they can cross-react with many of these different thyroid tissue, with different tissues in the body, like myelin, cerebellum, parietal cells, islet cells. That's why if you have, just think of the scenario. You have celiac disease, you get gluten exposure, you activate T cells very, very aggressively to destroy the gut lining. You get villous atrophy. These tight junctions open up significantly. You can get not just paracellular, but transcellular intestinal permeability, right? That's why we said we want to look at your permeability markers, see if it's transcellular. If it's transcellular, you should be thinking, is it celiac? Is it transcontaminase too? They get both those permeabilities. Gluten then crosses, you make antibodies. And the antibodies with gluten cross-react with several tissues because they're identical in their amino acid sequences. And now you develop autoimmune disease. And the most common area is the brain for celiac. So they get neuroautoimmunities. But they can get thyroid autoimmunities, they can get type 1 diabetes, those are also linked. So the key thing again is this celiac disease, you get this villous atrophy. Now the villi are important because that's what absorbs all the micronutrients. So if these microvilli are destroyed, you can get malabsorption syndromes. And on biopsy, they look like this, just shaved. Normal, celiac. Or I shouldn't even say celiac, transglutaminase 2. Okay, now, you will get some people that have transglutaminase 2 autoantibodies, but they can't fit the definition of celiac because they don't have the genotype. Do you understand? Like if they go to the Mayo Clinic gastroenterology department with the celiac disease specialist head department, they go, yeah, you've got villous atrophy, you've got transglutaminase 2, but you're not celiac because your genotype is HLA-DQ 1 and 2 and not 2 and 8. So you have something, but it's not celiac. It doesn't matter. Just know that transglutaminase 2 is the key thing here, okay? But what makes celiac so aggressive is the 2 and 8 gets that strong T cell response, so this is more likely with the 2 and 8 genotype, okay? Now, when you look at the diagnostic criteria, they'll look for crypt hyperplasia. So you'll see these immune cells all clustered together there, and then you'll see intraepithelial lymphocytes. You'll see more lymphocytes than normal. Like you see a band of them, you see these little bags, see these growth, you don't see them on this side, and you get the villous atrophy. So villous atrophy plus crypt hyperplasia, like these little coffins, these crypts all through, and then these epithelial, like lots of lymphocytes, is a characteristic histology finding for celiac. And again, the key thing with them is they have this exaggerated HLA-DQ. You see the HLA-DQ 2 and 8 here. These directly and aggressively activate T cells, and you get significant destruction of the intestines, where you can get microvilli damage, transcellular permeability. Okay? Now, here you see another illustration here, HLA-DQ dendritic cells. Those are the antigen-presenting cells. They sample the proteins. They come in, they have the genotype HLA-DQ 2 and 8, boom, you see activation of this T cell response, and then you see destruction all throughout there. So that's the key thing that I just want you to understand what makes things different, is this very destructive T cell response. Okay? So gluten sensitivity and celiac disease are not necessarily the same thing. They both make a person feel bad if they eat gluten, but gluten is very, 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 celiac disease or transglutaminase 2 autoimmunity with that genotype is very, very destructive. Okay? Now, what that means to you is if a person comes in and they also say, when I went off gluten, it changed my life dramatically, you always want to think of, did they have transglutaminase 2? Okay? Let's get into gluten sensitivity in general a little bit more also. So this is a breakdown of wheat, okay? And if you see wheat here, wheat has several portions you should know about too. Wheat also has lectins called wheat germ agglutinin. And there are many autoimmune patients that have sensitivities to lectins. Again, we're going to cover this again a lot next module. Talk about the whole lectin story in autoimmunity, okay? And these people may only show up if you test wheat, germ, or gluten antibodies. It's not going to show up as gliadin because it's a different section of the wheat protein. You guys have to think of gliadin or wheat as a tree with many, many branches. And alpha gliadin is one branch. Wheat, germ, and gluten is another branch. So there's some people that totally fall apart with wheat, but you test them for gluten sensitivity and celiac, and they don't show up because they're just sensitive to the lectin portion of wheat. And they don't actually have celiac or have gluten sensitivity, but when they go off wheat, they feel dramatically better. Now, when you find a person that has sensitivity to one lectin, they usually have sensitivity to other lectins. Lectins being nuts and seeds, and also found in your nightshade foods. Little seeds of tomatoes, little eggplant seeds, those are just loaded with lectins. So you'll see a group of lectin-sensitive people react to wheat, but never show up for celiac disease or gluten sensitivity, but it's life-changing for them also when they go off it. And then the protein portion of wheat is gluten, and there's gliadin, and there's different branches of gliadin, and there's glutenin. And there's transglutaminase, which is used to metabolize them in the gut. This is the target site for autoimmunity. This is transglutaminase. What transglutaminase does, it converts wheat to degaminated gliadin. And when they process wheat, for like food processing to make gluten not so sticky in their machines to make pretzels and things like that, they deaminate it, which makes it very reactive for some people. So some people only react to deaminated gliadin. Now, I made this chart in 2010, and then around 2015, I saw this on South Park. And I go, I made it. They don't know, but it was I'm like, that's all right, it's a copyright violation, but no problem. If you ever get to see this video, it's hilarious. Did you ever see it? Oh, YouTube it. I mean, it's not appropriate for some people, but it's funny. Okay, now, this is a study that was done. We found that 50% of these patients do not respond to alpha-gliadin peptides. So they were looking at gluten-responsive people that children have celiac disease. And they found is they can't find the alpha-gliadin marker. So this was a study that's published in Gastroenterology, where remember gliadin has different branches, alpha-gliadin, gamma-gliadin, right? Gliadin 17-mer. And like in this study, let me put it this way. When you get a lab test back and it measures gliadin, it's always alpha-gliadin. The only reason they'll tell you it's something else is if they test other branches. So when you get a lab test back, it says gliadin antibodies, it's always alpha. But the problem is when you only measure alpha is you miss it, like they did in this study with actual HLA-DQ genotypes. So in this study, they found 1, 2, 3, 4. Only this row is alpha. Look at how many they missed. So the way you want to screen for gluten sensitivity without question is this Cyrix Array 3. And let me tell you a few things about this test. Okay. Wheat is one large protein. So think of it this way. You have a large tree. If you have an antibody to the surface part of the tree, you show up as wheat antibody. If the immune response is to a branch of the tree, you show up with alpha-gliadin or gamma-gliadin. You know what I mean? So you have to check the whole tree, all the branches, and see where the immune responses are to really not miss it. And you also want to check things like wheat germ agglutinin, which is the lectin portion of wheat. So this panel will check the entire wheat proteome and really see if it's there. And then also it'll check for gluteomorphin. Gluteomorphin is the opioid response protein to gluten. And then there's some studies that show you can't find celiac or gluten responses unless it's gliadin bound to the actual transglutaminase at the same time. So everything that's been published to find gluten sensitivity as a reliable marker is on this panel. So this is how you don't miss it. And then you get an idea of what severity they have, okay? Now, do you guys see in the very bottom, it says transglutaminase 2, 3, and 6. So those are different. Those are not wheat protein markers. Those are tissue protein markers. That's where autoimmunity hits. So the top part of the panel with all the different branches of gliadin or looking at the gluten proteome, but when you start hitting transglutaminase 2, that's not a gluten proteome. That's the enzyme in the gut. Transglutaminase that is associated with villus atrophy and destruction and so forth. Transglutaminase 3 is the enzyme for skin. And many people that have gluten sensitivity just have severe skin reactions. That's associated with transglutaminase 3, and transglutaminase 6 is brain. Okay? So what I actually do when I see this panel, first thing I do is I just jump to the transcontaminases. And I go, okay, do they have the severe outcome or not? Is this an autoimmune response? And then if it's there, then I know. Now I put them in the category of unresponsive, chronic, complex, ongoing patient. If I just see gluten sensitivity, I go, yeah, that's common. And don't eat it. It's because it's going to cause you to be really inflamed and so forth. But anyways, that's the key thing there. So do you guys understand the difference between transcontaminase and celiac versus gluten? That's why it's so important. Now, if you have people that have gluten sensitivity or even celiac, one of the key things is when they get exposure, it's going to happen, right? So accidental exposures take place. And they can really put a person in an inflammatory immune state at different degrees. Some people will be inflamed for many hours, some people will be inflamed for many days. Some can really fall apart and takes several weeks to recover after an exposure, depending on their degree of sensitivity and immune reactivity to gluten, especially those that have HLA-DQ celiac types. So one of the things you can also do is you can nutritionally have patients that have gluten sensitivity or celiac do things when they get exposure accidentally. So the key thing is, first of all, a specific enzyme called DPP4. DPP4 enzyme is what digests gluten and casein. So if we have someone who gets accidental exposure, we make sure they start loading up on it. And they'll have to experiment with what dose is involved. And then if you look at the response with gliadin, you see this interleukin 15 response. You guys see this down here, IL-15? Well, in studies where they looked at T-cell responses from gluten exposure, the things that have been found to dampen it are aloe vera, quercetin, luteolin, apigen, and lycopene. So in my practice, when I find people that have gluten sensitivity or celiac disease, I give them a product that has these things all in it. But the point is, they use it for accidental exposures. Or if they travel, they just take it with their meals just because they do the best they can, but they're not sure what they're getting exposed to. And these are basically the compounds, DPP-4-ase. Okay? Those are the mechanisms that works. So that's one part of gluten sensitivity. Now remember, as long as the gliadin protein stays the protein, it's going to continue to stimulate the immune response. The minute it breaks down to amino acids, it's no longer immune reactive. That's why it's so important to take the enzymes to break down the protein structure, because the antibodies can only bind to the protein structure, which perpetuate the ongoing immune response. Okay? That's why the DPP4 is so great. Now, hydrochloric acid and pancreatic enzymes can also break down, gluten proteins. So they're good too, but the DPP4 is very specific. All right. Now, the other key thing is that people that have gluten sensitivity or celiac, many of them don't get better when they go gluten-free. So there's a large percentage of celiac disease patients that do not get better when they are on a gluten-free diet. They still have malabsorption syndromes. The villus atrophy never goes away. And that's because there's foods that are very similar to gliadin, and they cause cross-reactivity. So gliadin and casein, they're so similar they can bind to each other's, these antibodies and antigens can bind to each other of their similarity of their amino acid sequences. So if you find patients that have gluten sensitivity, and especially if you find patients that have celiac, you want to look for the cross-reactive foods. And this is why Cyrex made their cross-reactive food panel, because they're not going to respond to it. For the most part, if they go on an autoimmune paleo where they avoid all grains and dairy, they're going to avoid the cross-reactive foods. Because the cross-reactive foods are, for the most part, grains, as you can see, and casein. Coffee has been found to be only contamination, cross-contamination with gluten in there. It's not the actual clean coffee. And I remember Dr. Vijitani tested in his lab different coffees. And if they were in a can or in the supermarket, they were all contaminated. Starbucks was not contaminated because they don't transport anything besides coffee. See, the problem is when you have a manufacturer that transports many different things in their wells or however they transport their ingredients, you can get contamination there. But when you have a company that only does one thing, which is coffee, then there's no contamination. So, if you have celiac disease, I would just stick to Starbucks. I don't know about Pete's. I don't know about other coffees. But the key thing is how they're transported in the coffee beans as a manufacturer, because there's definitely cross-contamination with most coffees out there. Okay. So this is what this chart is showing you. It's showing you immune cross-reactivity. So intestinal permeability, gluten reactivity, you have a vicious cycle, and then you have cross-reactive foods, and then you can get autoimmune target reactions. Transglutaminase 2 is intestines, 3 is skin, 6 is brain. The ones we didn't talk about is GAD, cerebellum, and islet cells. GAD is the enzyme in the brain called glutamic acid decarboxylase. It makes GABA. People that get this end up with anxiety disorders, end up with vertigo, and cerebellum, they get ataxias, and islet cells, they get type 1 diabetes. And this is the immune cell activation by molecular weight. They can lose their tolerance. The concept of cross-reactivity is when you have amino acids, if you have proteins, if the amino acids are similar in structure, then an antibody from, let's say, gliadin can bind to cerebellar tissue. And when you look at dot blot, this is dot blot analysis. It's not a lysis, it's dot blot. So what you have here is, I'll show you, these are wells. And you can see in these wells here, vertical axis, that's gliadin peptide. That's purified, pure gliadin. And this is crude gliadin, it's not purified. And here you see cerebellar protein on these wells, then myelin basic protein, and then egg, and then soy. So when they take cerebellar antibodies, and as a control, they take cerebellar protein, they should have a reaction, because antibodies bind to antigens and it turns this color, right? It's a normal response. But cerebellar shouldn't bind with gliadin. That's cross-reactivity. This is what happens. And then look at this, cerebellar and egg. So now cerebellum antibodies, egg is an issue. So anyways, so this is the cross-reactivity model. And then in studies, they look at people that have transglutaminase 6. This is a case study that was published in Journal of Neurology and Neurosurgery and Psychiatry. They look at MRI of a patient that had gluten ataxia, and they showed within 15 months degeneration. You see the hyperintensities, that's demyelination, progressed to this. So that's why it's so serious. So if someone has transglutaminase 6, it's not the same thing as gluten antibodies. Someone has transglutaminase 2. This is transglutaminase 6. As a matter of fact, by the way, if you guys see a patient come in that has gluten sensitivity, immediately do Romberg's test. You guys remember Romberg's test? Have a patient just stand and then close their eyes, see if they fall, and then take it one step further and do a tandem one where they cross their legs together and then stand and then close their eyes, okay? And see if they have any issues. And usually you also, when they walk, people that have cerebellar issues like this, they'll have like a wide stance gait. Their feet will come across their shoulder. You sit like they walk in, have a history of GI issues, you see a wide stance gait, close their eyes, they fall all over. You definitely want transglutaminase 6. If you don't get it, you don't find it, and they continue to get exposure, even with gluten or other grains, goodbye brain. Okay? So anyways, so that's the whole issue with unresponsive, with celiac. Everybody okay with that? Okay. Now, as we finish off this, let me just say this. Gluten sensitivity is a serious problem. Many people that end up with leaky gut, intestinal permeability, end up with gluten sensitivity. And that causes ongoing inflammation, ongoing systemic inflammatory responses throughout the body. It's not a good thing. So gluten sensitivity is a big deal. And there are many publications now that show gluten sensitivity alone is a major issue for brain inflammation and a serious problem for systemic inflammation, autoimmunity, unrelated to celiac. Okay? But gluten sensitivity, if you improve oral tolerance, if you improve the permeability, you can really dampen the response, okay? Celiac, you can never dampen it. Because if they get any trace exposures, that HLA-DQ2 is so aggressive, you can do whatever. You can fix the leaky gut of a celiac patient. Within one traced exposure, the whole thing will fall apart immediately, within minutes. And then it all opens up. T cells are so aggressive that you get significant destruction. So this is also why, one of the things I was saying yesterday, please don't be the person that goes, well, I'm going to get them off gluten anyways. Why do I need a test? Because it's a big difference in how they respond. And the other thing we talked about yesterday was if you're looking at intestinal permeability, once you see transcellular permeability show up versus paracellular, you got to rule out celiac. And ruling out celiac would be looking at transglutaminase 2. Right? That's the key thing. If you want to know the specific genotype, you'll have to test their genotype, HLA-DQ2 and 8. Every lab does it. So it's like LabCorp, Quest. It's not a big deal to test those genotypes. Okay. Now, let's move on from celiac, which is one form of intestinal autoimmunity, to the rest of the intestinal autoimmunities, because these are also, again, you're going to be suspicious of them when you see a patient that has conditions that just don't get better, they're constantly getting worse, nothing's helping them, they have to eat a certain way or they can't function. You see transcellular permeability on their intestinal permeability test, right? They're having chronic symptoms. So when you look at intestinal permeability, we're also going to start top down. You can have intrinsic factor, parietal cell, and then ANCA, ASCA, which are associated with Crohn's and ulcerative colitis, and tropomyosin. Those are the main target sites for intestinal autoimmunity. So I'll go through each of these one by one. Intrinsic factor autoimmunity, what's happening here is these are the ones that end up with megablastic anemia. This is actually pernicious anemia. Okay? Now, the reason you need to know this is that if you guys are doing routine lab work, let me say this. Have you ever had patients come and say, I have anemia, I've always had it? That's never good. You're like, that doesn't matter, we have to find out why. Oh, really? No one else cares? I'm like, we care. It's gonna be the central part of why you're not getting better. Okay? If you see an ongoing megablastic anemia and nothing's helping, and oral B12 doesn't do much for it, you have to rule out pernicious anemia. What's the difference between megablastic anemia, which is only B12 related, and pernicious anemia? They're both the same megablastic CBC pattern: high MCH, high MCV, high MCHC, low hemoglobin, low RBC. The difference between the two is intrinsic factor blocking antibodies. So some people have B12 deficiency issues because they don't get enough B12 in their body. Most common cause is actually hypochlorhydria for non-autoimmune issues. They don't have enough hydrochloric acid to absorb B12. So if you see a B12 anemia pattern, like a megablastic pattern, make sure they don't have hypochlorhydria or an H. pylori infection, and also make sure they don't have intestinal autoimmunity, intrinsic factor blocking antibody. Okay? If they have pernicious anemia, intrinsic factor blocking antibody, it will not be the only autoimmune disease they have. Just so you know. So now you're going, where's the rest of it? So literally, you could have a chronic patient come in, you go, hey, let me share the past lab work. Oh, B12 anemia. And I'm like, yeah, it never responds to B12. I take it all the time. I even had B12 shots. Kind of budged them a little, didn't make much of a difference. You go, have you had intrinsic factor antibody checked? What's that? We can check it. Comes back positive, you go, okay, this person has autoimmunity. Where's the rest of it? It could be transcutaneous too, it could be celiac, it could be thyroid, it could be myelin, it could be anything. But it's very rare that it's just intrinsic factor. Okay, so that'll be one way you'll see it. So the key thing, and by the way, this is the megablastic pattern: low RBC, hemoglobin hematocrit, high MCV, MCH, MCHC. If you guys see that, they can't absorb B12. Usually you also see high homocysteine with that. Then you want to run the intrinsic factor blocking antibodies. The mechanism is normally when your stomach parietal cells, they release intrinsic factor, it binds with B12, and B12 bound with intrinsic factor can cross the small intestine. When people have intrinsic factor autoantibodies, the autoantibody blocks intrinsic factor, destroys intrinsic factor, so it can't bind to B12, so it can't get into the GI tract. The best test to measure B12 is not serum B12. Serum B12 is the worst test. Serum B12 will be positive, lots of false positives, because if you measure serum B12, if someone's taking a multi, it'll always be off the charts high, because they're measuring what's in the blood. Your best marker for B12 deficiency is a marker called methylmalonic acid. It can be done in the urine or it can be done in serum. So that's your best marker, because B12 is used to metabolize methylmalonic acid. So if there's not enough B12 there, you get high levels of methylmalonic acid. Okay? So what you see all the time is this literally, I've seen this, I don't know how many times, I can't even count. Patient comes in, they go into the healthcare model, they end up with megablastic anemia, it's high. They test their patient's blood with serum B12, it's off the charts, and they go, well, you're not B12 deficient. Some people just have this. Oh well. And that's it. That happens all the time. I'm sure you guys have all seen that too. And the problem is they don't understand serum B12 can be skewed as soon as you take it. Okay? As a matter of fact, you should expect the range for serum B12, I don't know, but it's 200 to 1,000, depending on the lab use. If they're taking any multi, it'll be like 10,000. It'll be like 10 times the range or something. It'll be very high. And that's normal when you take a B12 vitamin and it gets in your blood and they're measuring the amount in your blood. It doesn't mean you're going to absorb it all. It just means that's what's in your blood. Okay? So that is intrinsic factor blocking antibody. Know about that when you guys see it. Red flags should go up. If they're kind of with any GI symptoms, like everything now changes. The next intestinal autoimmunity is parietal cell, ATPase autoimmunity, and this is autoimmunity against the gastric lining. Now, the key thing with this is that this autoimmunity is going to present itself like a gastric ulcer, but it's not going to respond to anything. So the minute you see a person that has gastric ulcer, gastric reflux diagnosis, whether with endoscopy or just symptoms, they try a natural approach like the glycerized licorice, doesn't help. They take antacids, doesn't help. They take protein pump inhibitor, aggressive versions of it, doesn't help. They do triple antibiotic therapy for H. pylori, doesn't help. One of the likely diagnoses is autoimmune gastritis. And you'll see the parietal cell ATPase antibodies, positive, and this autoimmunity actually destroys the gastric lining. By the way, the other key thing you have to rule out, if someone has those symptoms, is gastric carcinoma. For sure, run a serum gastrin, make sure it's not off the chart. Make sure they get evaluated by the gastroenterologist to rule out gastric carcinoma if nothing is helping an ulcer. It may not be an ulcer, it may be an actual tumor. Okay, so that's another one you should know about. Make sure you look for that. And this changes everything too, because now, guess what they can't take? Hydrochloric acid. Guess what? Their entire gut downward is now going to have a different pH. It's not going to be sterilized. They're going to end up with all types of issues. They're going to end up with small intestinal bacterial overgrowth. They're going to have to end up like on a FODMAP diet just to function without bloating and distension. They're going to have yeast overgrowths, bacterial overgrowths. You're going to have to give them all these things to treat and deal with it all the time because they can't get that initial acidity working anymore. And over time, their parietal cells will just degenerate all the way through. So they're going to be unresponsive. They're going to be ongoing care. It's like survival. Okay. Now, the next three autoimmunities are autoimmunities against the intestinal tract itself. So anti-Saccharomyces cerevisiae antibodies are antibodies to these actual yeast structures within the gut. And then this, I'm sorry, this one of these should be ANCA. We'll have to correct this on the one. Anti-neutrophilic CA antibody, we need to check those, and then tropomyosin. These are smooth muscles. But when you have antibodies to the intestines, you get this inflammatory condition. So Crohn's is characterized by inflammation throughout the entire colon, and then ulcerative colitis is more of the distal colon. But when they do colonoscopy, they can see this cobblestone presentation with Crohn's and with ulcerative colitis to see this pseudopolyp presentation. It doesn't really matter. It's all intestinal autoimmunity. And then tropomyosin is another target protein that attacks the smooth muscles. And by the way, tropomyosin antibodies are also common to cause chronic interstitial cystitis. The smooth muscles of the bladder can also constantly be attacked. People that have ongoing interstitial cystitis have no infections. They keep having symptoms, but they have no urinary tract infections. You have to suspect tropomyosin antibodies. If you see tropomyosin antibodies, those antibodies can also destroy the smooth muscles of the gut. So that's another red flag. Someone comes in and goes, hey, I have interstitial cystitis, but I never have any infections. Nothing really helps it. It gets worse when I'm under stress. You run tropomyosin antibodies, you know they're going to have an ongoing gut autoimmune problem too. Okay? So these are the different symptoms. The key thing with these autoimmune issues is they get the urgency. They have to get urgency of bowel movements as they get worse and worse. They have bloody stools. The more inflamed they get, the more bowel urgency they have with severe cramping pain and discomfort. They end up with malnutrition. They can end up with malabsorption problems. And these are the target antibodies. So those are the key things. Now, what you do is, this is just a list for you of all the symptoms they have. These are the antibodies. This is correct. ANCA antibodies, ASCA antibodies, tropomyosin, and transglutaminase 2. When you find someone has intestinal autoimmunity, with any of these antibodies, intrinsic factor, parietal cell, ASCA, and trypamycin, if you see these antibodies, and by the way, you can screen for all these with Cyrix Array 5. They'll check for these and all the other ones. So whenever you see one in general, here's the important clinical pearl. Whenever you see one autoimmune disease, look for everything else. Cyrix Array 5 will screen all the major tissue proteins really quickly. The 24 tissue proteins. I think it's 24, 25, but it'll just screen for all these very fast. And then you'll see if they show up with any one of these, they have intestinal autoimmunity. They're a whole different candidate. And then in the early stages, you only see the antibody. When you guys see these changes, these are really progressed. So many times people have chronic GI issues. They'll go to a gastroenterology department. They'll do a scope, go, there's nothing wrong. Sorry, it's just a little bit of inflammation, but nothing. But when you check the antibodies, you know that they're autoimmune. And then within time, they'll eventually get to this point, but they may have a normal colonoscopy in the very early stages for maybe 5, 10, 15 years. But they have chronic GI symptoms without any colonoscopy changes. This is progressed. This is like so serious, so severe, and tissue so destroyed. But way before they develop any of these symptoms, they'll have a normal scope, just like this. And then they'll have these antibodies, and they'll have symptoms. So you just have to know that they're autoimmune. If they don't get managed, they're going to progress. So what you see here is what I wrote down for you is like the antibodies and then future studies of where they're going to show up problems with. So for example, if someone has intrinsic factor, always look at methylmalonic acid, look at their B12 level, see if that's getting better, because if their autoimmunity is calming down, then there won't be as much attack against intrinsic factor, and they can start using B12. And these people need B12 shots too, so you have to be careful you don't misinterpret the B12 injections versus the autoimmunity. And then people who have parietal cells, if their burning continues, they need an upper endoscopy. Make sure they don't have also H. pylori with it. It can make it a lot worse because H. pylori antibodies have molecular mimicry with parietal cells. So it can be devastating. They also have the infection. And then ASCA, ANCA, trypamycin, if they have these, then you want to do some follow-up future studies to make sure they're okay. So that's the intestinal autoimmunity story. What I'm going to do next module is we're going to get into autoimmunity and go, here's how you really dig down into tolerance. Here's all the things that we know trigger autoimmunity. Here's agglutination, here's citrullination, here's haptenation. These are all different chemical processes. This is how cross-reactivity is different than citrullination. People that have rheumatoid factor have agglutination. These are the foods that are associated with agglutination. It's in depth, okay? I promise you have not heard this information anywhere else, because I haven't. It's all in the literature, and it's pulling it out piece by piece, and I've been using it as a clinical model for a long time. So we'll be going into really great depth of what to do for autoimmunity. It's not, it's hard, but at least a better understanding. We just don't have time in this GI module to just talk about it. All I can do in this GI module is go, hey, fix what you can, improve the gut, know that unresponsive GI issues could be autoimmune, and be aware of that in your diff die. Okay? Now let's get out of autoimmunity into another area, which is this whole brain-gut axis, enteric nervous system, and how this can cause chronic non-responsive GI issues. So when you're looking at these GI issues, remember the vagus nerve? The vagus nerve is kind of the interplay, the interface. Look at the title of this paper, Vagus Nerve Stimulation at the Interface between the brain-gut interactions. So as your brain fires, it fires into the brainstem fires into the vagus, fires into the gut plexus, and this is part of a normal immune response. And the vagus complex, the vagus nuclei is in the brainstem that then projects into the vagus nerve throughout areas of the gut. They really are involved with all types of things, including autonomics, so they get blood flow to the gut. They help release digestive enzymes, and they help with contraction and intestinal motility. So when someone has this function of activating their vagus, like when people that get neurodegenerative diseases, people that get traumatic brain injuries, and they lose the ability to fire into their vagus, they can't get these responses to be healthy and normal. So their motility is impacted. They can't get blood flow to their gut, so their intestinal epithelium just sheds away because there's no blood flow there. It just dies off. It's like blowing off leaves. It's just whoosh, it's gone. And they end up with significant motility issues. That's another killer to you. People that lose their brain-gut axis mechanisms, their chief complaint will be things like constipation. They'll come in and say, I have constipation, and nothing has helped it. What have you tried? I have tried this and that and this and that and this. And then those people will typically say, I have to take magnesium to function. That's another key thing you'll see with motility problems, because magnesium is a stool softener, right? So when people like don't have aggressive contractions of their gut, they have to soften their stool in order to have bowel movements. And by the way, that's a good thing for them to do also. If they have brain-gut axis issues and that motility pathway is not working, magnesium at a dose high enough where it can soften their stool would be ideal. And the way you actually find it is you have a person start taking magnesium, dose it up each day. I take it at night each day. Next morning, the one that causes the watery bowel movement, the dosage, let's say it was 10 capsules, you cut down to, let's say, 9. And that's the dose they need to keep their magnesium levels to keep their stool soft so they can deal with their motility issue. And you'll see people that have brain-gut axis issues and something wrong with their motility pathways will be just doing that on their own. They'll come in and tell you. Like one of the things I always do with my patients when they have like their huge list of supplements, you go if you've seen that, put on your table. I go, okay, you're going on an island and you can only take 3. I'll be back in a minute. Some of them like get anxiety. They're like, if magnesium pops up, you should be thinking about the brain-gut axis, especially if they say that it's the only way they can have bowel movement. Okay? Now, these the vagus actually eventually gets into these enteric plexus. So you have your enteric plexus that fires into the mucosa. These are some great papers you guys can read if you guys really want to understand the brain-gut axis pathways. I've included them in your course material. So if you see some of these diagrams you really want to learn more about, check out the papers. They're very good. Okay? I just want to get into clinical issue. And then here you can see the vagus activating the enteric nervous system, and you see this is the microvilli. I mean, these nerve plexes go all the way up here. They impact every aspect of visceral function. And then you get visceral afferents and efferents back to the vagus. So output to the gut, and from the gut back, all takes place to the vagus. It's a bidirectional pathway. Now, the most common disease that's going to impact the brain-gut axis and cause chronic constipation that nothing fixes is Parkinson's. In the early stages, we talked about this a little bit yesterday, that alpha-synuclein aggregate builds up, and as it builds up, it starts in the olfactory bulb, and it starts in the enteric plexus, and then it migrates up into the vagus, and then the vagus gets destroyed, and then you get a person who has chronic constipation. Okay? Now, both the enteric nervous system and the dorsal motor nucleus of the vagus are affected by Lewy body pathology at early stages of Parkinson's disease. This early involvement provides insight into the pathophysiology of gastrointestinal dysmotility and this disorder, and may constitute an important step in the idiopathogenesis of Lewy body disease. And then you see here, this showing it's really the dorsal motor, the vagus nuclei that gets involved. And in conclusion, they show studies that it's alpha-synuclein breaking up in this issue, and then studies that show it also causes permeability. So it's a key factor. When we get into evaluation, I'll teach you how to look for all the early signs of Parkinson's and Parkinsonism with a little more detail. But you definitely want to consider like their gait and so forth, and they're important too. The other key thing is just this brain issue and dysautonomia. So unrelated to neurodegenerative disease, you can have patients that have autonomic disorders, dysautonomias. And what happens to them is they get injury to their brain and they can't control their autonomics very much anymore. And it could be a head injury a while ago. If you guys attended our neuroinflammation course, we talked about glial priming. Someone gets a head injury and then 5 or 10 years later, their brain continues to degrade and they get to the point where the autonomic centers get impacted. So now they start to show up. So you won't always see head injury, gut issue. You'll see head injury, okay, for a couple of years and then starting to decline and then gut issue. And that's all the key things with glial priming. So that's from the previous module. But you'll see many of these people that have dysautonomia patterns, and we'll talk about those, and they have dysautonomia that's basically they're having issues with the vagus. And then you can also have demyelination that's taking place within the brain. So neurodegeneration, demyelination, dysautonomias are key things to consider. Some neurodegenerative diseases like different variations of Parkinsonism, like multiple systems atrophy, they'll impact autonomic centers. So injury to the brain, autonomic centers through demyelination, MS, neurodegenerative diseases, variations of Parkinsonism, traumatic brain injuries, glial priming that's added up, they can all cause these disorders. Okay? And these are just some images of see, you guys see these areas that are in blue and red? Those are the areas of the brain that control autonomics. Here's parasympathetic, here's sympathetic. And if any of these areas get injured, you've got dysautonomia. And then you have problems with the gut functioning, you have problems with motility, you have problems with blood flow, you have problems with enzyme release. So these patients become unresponsive. So you're treating their gut just to get through the day, but you're not necessarily, going to reverse it by treating the gut. You're going to, if anything, you have to start working on the brain or having to do things to improve the brain function. The other key thing is vestibulopathies. Vestibulopathies are really important. The vestibular system, like your inner ear system, fires directly to the vagus nerve. So when people have inner ear infections, or they have neurodegeneration, or they have Meniere's disease, or things like that, those vestibular inputs are not firing properly, and the projection of those are right into the vagus, into autonomic centers. You guys ever been on a roller coaster and feel nauseous? The reason is because you're getting tremendous vestibular input by spinning and moving all around. And those vestibular inputs fire directly into the vagus, and that's why sometimes people throw up. That's a pathway that's just connected that way, genetically, just right into it. The divisions of the embryonic divisions of development of the brainstem nuclei involved with the vagus are genetically yoked with tissue that are coming out of what's called the brachium pontus of the cerebellum and the vestibular pathways. So as you activate one, you fire directly into it. It's just a genetically linked hard pathway. Not a genetically, embryologically linked hard pathway. So you have to be careful with those. And people that have gut issues, you know what you do? If you suspect a vestibular issue, you just do this. Take your finger and go, watch my finger. There you go. How do you feel? Oh, I feel nauseous. Go, okay, we diagnosed you. You have vestibulopathy dysautonomia. That's why your gut's not getting better. It's really common. Or sometimes, like I have, if you see my carpet in some of these case studies, it's got some, lines in the carpet. Patient will come in and go, oh, I'm going to throw up looking at your carpet. You're going, great, you have a vestibulopathy. While you're here, I have chronic gut issues. Okay, I think we're getting your diagnosis. So be aware of that. These vestibular disorders can cause these ongoing dysautonomias. The vestibular system fires directly into, this is a good paper if you want to read more about vestibular sympathetic responses. This shows how the vestibular system directly fires to brainstem areas like the NTS and the vagus, where you get these autonomic responses. But for the most part, if you look at the mesencephalon, the midbrain area, there's an area right here, which when activated to the vestibular system causes sympathetic issues and dysautonomias. Now, the way you find autonomias is you have like episodes of racing heart, sensitivity to light, difficulty relaxing, diverse neurological symptoms after meals, and chronic gastrointestinal symptoms. Let me explain a few of these. If you guys have a pulse ox to measure heart rate, it's just, if you see it and it looks broken, think of dysautonomia. And I always recommend 2 pulse oxes because you can't have error in both. So if you put one on the left and one on the right, and then you're looking at it, right? And they see both of them like all over the place. Like normally you put a pulse ox on someone and it's like within a few seconds it'll say heart rate, 72 beats per minute. Then it'll go like 72, 73, 72, 73. That's like normal response, right? Dysautonomia, 72, 83, 92, 85, 102. And you're going, what is going on? And if you see it on both sides, you go, listen, they're not both dysfunctioning. That's dysautonomia. You see that, you see like they're very sensitive to light. A lot of these patients with dysautonomia, like they prefer you do your exam with the lights down. They don't like bright light because they have problems constricting. Their constriction and dilation is a sympathetic parasympathetic balance. That's hard for them. They have a hard time. It's easier for them to just be in darkness versus like bright lights. Hate flashing lights, hate sound. And the key thing also with them is they'll eat and they'll have like the weirdest symptoms. If I eat, I see colors flashing in my visual field. If I eat, I get tinnitus. If I eat, I get vertigo. If I, stuff like that. If I eat, I get a migraine. It's the weirdest thing. But only if it's a large portion. Or they'll go into like, so what happens is when you have dysautonomia, when you eat, you have to get blood flow to the gut. And when they can't shunt their blood flow properly from their gut and brain, they'll get all these weird neurological symptoms. So when you see the dysautonomia patient, that's what they'll tell you. Portion size makes them have symptoms, but just eating causes all these diverse neurological symptoms because they're having problems shunting blood from their system into their gut and their brain also. So some will have vertigo, some will have migraines, some will have, depends what part of the brain gets impacted. If they hit their occipital lobe, they'll have flash of light. If it picks up the vestibular system, they'll get dizziness. If it hits their autonomics hard, they'll get a migraine. So that's the key thing. It has nothing to do with food sensitivity. It's dysautonomia, okay? And then people that have traumatic brain injuries. This is the paper I included in your notes. I did a review of the literature on traumatic brain injuries and talked about all this research on dysautonomia. So if you guys want to read more about those mechanisms, you can check out the paper in your reading material. And we know that we talked about some of these in the previous module, but this was a great study where it showed when they caused animal head injury and they lost the ability to activate the vagus, that they ended up with their tight junctions within minutes breaking. So they got this permeability issue. This is just from the brain not getting enough vagal activity. And then when they actually went in there and stimulated the vagus with these brain injuries, they found that had a significant impact on their degree of intestinal permeability. So sham control, no intestinal permeability. When they caused a traumatic brain injury, they had significant intestinal permeability. When they activated their vagus, their intestinal permeability went down. And it was just to show that it's really this brain connection to this intestinal permeability. And then this is the slices of the gut. Sham, no change. Control, traumatic brain injury. You can see the intestinal barrier just dissolving away, leaves being blown away because there's no blood flow there. There's no autonomics controlling that. And when they activate the vagus, there's some responses there. So in treatment, we'll talk about like doing gargling and doing various activities to stimulate the vagus to get that enteric nervous system to work. When you see dysautonomias or you see traumatic brain injuries or Parkinsonism, those are critical, okay? Now, let's move on from the brain-gut axis to the enteric nervous system. And the enteric nervous system is also involving injury to the astral nerve plexus. And one of the areas where you can injury to the nerve plexus is diabetes, Parkinson's, systemic inflammatory conditions, Crohn's. So let me put it to you this way. The gut nervous system is very vulnerable. If you have any inflammatory gut condition for many, many years, it can degenerate away those nerves. That's why they have Crohn's on here. So these are enteric neuropathies, meaning the enteric nervous system is destroyed. So Crohn's, any systemic inflammatory disease, especially systemic inflammatory disease of the gut, for many, many years is going to degenerate the gut. So when you have a patient that has had Crohn's or ulcerative colitis for 10 years, 20 years, guys, they may not have much left. Like they'll have to take magnesium to have softened stools, to have a bowel movement. They're gonna have to activate their vagus. It's just the way it is. And those people need to be treated like a neurodegenerative patient. You have to do things to optimize the nerves. Everything we talk about neuroinflammation applies. M1, M2, you can do all those different strategies, but it's a key issue. Many people that have chronic uncontrolled diabetes have nerve plex injury. And by the way, if you guys are starting to see neuropathies in their feet, you're probably gonna have them in the gut too. They get to the point where their diabetes is so uncontrollable and they've lost their large diameter fiber, like you get a diabetic patient, you take a tuning fork, put it on their bottom of their foot, go, do you feel the vibration? They're like, no. You probably have some enteric neuropathies too. There's a systemic inflammatory response, okay? So be aware of that. So you're gonna have these motility issues and chronic GI issues with your uncontrolled diabetes that are starting to show with peripheral neuropathies, your chronic inflammatory autoimmune gut patients. Someone's had celiac disease for 10 years and never diagnosed it. They may have lost their gut plexus by then. And then obviously there's tumors and things that are more serious. So the nervous system does degenerate, and this is one of these papers I showed you yesterday, but it shows, the gut nervous system is just as sensitive as the brain, and chronic inflammation, those same mechanisms destroy it. And these are some other papers that really just go into these types of scenarios. Now, the most common cause, by the way, is still Parkinson's disease. And Parkinson's disease is the most common area of destruction. And they did these studies where they did vagotomies, where they took out the vagus. And what they found was when they had vagotomies, that the Parkinson's rates went down. And this is some early research showing that it does start in the gut and then go up the vagus nerve. Now, when you get tremor is when the protein aggregations that go up from the gut and from the olfactory bulb and the smelling pathways is when it hits the substantia nigra deep in the midbrain. That's when you get tremor. So that whole process could be 10 to 20 years. Constipation is a common problem in Parkinson's disease, occurring in about 50 to 60% of patients. It may occur even before motor symptoms appear. 10 to 15 years before motor symptoms. And then, we'll talk about this a little bit more. Let's just give you a few things. The first characteristic sign of Parkinsonism is loss of smell. Which scents? Peppermint, anise, coffee. That's what the researchers showed. So I showed you some of that yesterday. So when we do a gut exam, you're going to be checking smell. And we're going to be checking those three right away. Because you want to go, do they have early alpha-synucleinopathy? Starts in the olfactory bulb. These are the three scents they lose first. You see someone that is certain, and by the way, early onset Parkinson's start around age 35. You don't have to be 70 or 60 to have Parkinson's. And these symptoms start 10 years before they get tremor. So our part of our gut exam is to make sure they don't have Parkinson's. So they lose smell. Then another thing that happens is they get slowness. They get hypokinesia. So you guys, if you look at hand speed, they'll get slow. They'll move slow. The other key thing is their handwriting gets smaller as they write. Actually, one of the things you can do is you have them write a sentence, like, I don't know, today's like a sunny day. And they write it 10 times. And by the time they get to the last one, their font size is smaller because they get cramping. Their most motor system, before they get tremor, has rigidity. Or they'll complain of rigidity. They'll have either a tight hip, frozen shoulder, frozen hip, can't smell, peppermint anise coffee, chronic gut issues. You're looking at early Parkinson's. You can't call them Parkinson's disease yet. You just say early Parkinsonian presentation. Okay? And then they also have sleep disturbances. The other thing that happens with them is get restless leg. They have a spouse. Their spouse doesn't want to live with them. They start beating up everyone around them as an early sign as well. Or they'll hit their hand or hit their body parts or fall off blood while they're sleeping because they start jerking all throughout the night. So those are things you need to be aware of. This is the 10 early signs of Parkinson's disease. I don't know how early some of these are, but you'll also notice that when they talk, their voice starts to fade out, and they start to get like a little softer voice when they talk. So they'll come in and you'll do a history with them, and they're telling you their story, and as you start going on, it seems like they're whispering. That's an early feature. You see that with some frozen shoulder, loss of smell, chronic constipation. You're knowing you're probably dealing with some early alpha-synuclein buildup in their gut, causing their chronic constipation. And by the way, when you don't have motility, what happens to bacteria? It overgrows. What happens to yeast? It overgrows. And when you start damaging your nerve plexus, you can't get vagal activity and autonomics. What happens to enzyme levels? So if you do a digestive stool analysis on them, guess what you see? Bacterial overgrowth, yeast overgrowth, enzyme deficiencies, because the environment of the gut's different. So be aware of those. And then at that point, your clinical strategy will be to a neurodegenerative prevention model, and then try to get their gut function the best you can. Okay. And then one of the earliest things you also see is their gait. Let me show you some gait videos. See how this guy stooped over? See how he's looking where he's walking? See how his arm swing isn't that great on the right arm? That's the early presentation. Look at her. See how she's shuffling? See how her arm swing is not that great? So they lose arm swing first. This is shuffling. That's pretty progressed. See no arm swing? See how she's all over the place? So one of the early features is they lose arm swing, usually on one side versus the other. You see loss of arm swing, slowness, frozen shoulder, frozen hip, can't smell coffee anise, your whole game changes. Could they have intestinal, like if you worked them up, could you find intestinal permeability? Yes. You'll find it. It'll be there because their nerve plexus are destroyed. They can't get proper blood flow to their gut. They can't keep their tight junctions healthy. If you give them supplements, you're not going to see a change. This is why this is under the list of unresponsive. Because, again, the key point that I started with, don't be clinically naive. Understand the pathophysiology so you know like what to expect. You're gonna expect these people to have leaky guts and dysbiosis and yeast overgrowth and candida overgrowth. All that's going to be there. You can still manage and treat those things. It's going to be ongoing to improve the quality of function. Then you have to make the choice, and they have to make a choice: is it worth all the effort? Did they really see benefits doing it or not? Some people will. Some people that have Parkinson's, have their gut totally destroyed, cannot handle any sugar or yeast, or they don't feel well. Some people have to follow a strict FODMAP appetite because their gut's totally destroyed. Some still feel okay, but you have to watch and make sure they don't get worse. Some have to take enzymes or they won't digest their food. Does that make sense? So you have to kind of work with what you got. So this is a chart I made. It just shows you early signs. So again, earliest signs of Parkinson's is loss of smell, but no one knows that until you check it. So the key thing actually in the clinical exam is what I was trying to tell you yesterday. They don't have a favorite food. They don't have a favorite restaurant because when they lose their sense of smell, they lose their sense of taste, and their lifestyle of going out to eat is the first thing you'll find with their history. If you talk to them with social things they do. Then their chief complaint, they'll probably come in, it's chronic constipation. Like nothing's helping their constipation. And then you might see slowness of movement if you see how they walk and how they move around. If you test like rapid movements, you'll see slowness of movement. Usually it starts in one limb and then progresses to the other side. And then as they progress, they start to have balance issues, and then they start to have writing cramps, their voice starts to change, and then here is tremor. From here to here could be anywhere between 10 to 20 years. From constipation to tremor can be 10 to 20 years. So everyone's going to fail on their GI tract from 10 to 20 years if they don't understand brain-gut axis. And here's the problem. That early constipation is your window as a clinician to go, let's try to reverse your neurodegenerative disease. Because that's when you have a chance. That's when you get, let's not make sure this gets any worse. So you don't ever want them to get to the point where they have tremor and their voice gets impacted and so forth. Okay? So those are all enteric nervous system issues. And then you have small intestinal bacterial overgrowth. Now, small intestinal bacterial overgrowth is not an infection of bacteria. It's not an inoculation of bacteria. It's bacteria that's moved from the small intestine to the large intestine. Okay? So actually, let me skip a few slides. I'll show you this in a second. But remember, you have this valve, the ileocecal valve, between the small and large intestine. When you start to have destruction of the enteric nervous system, that valve opens up, and then bacteria from the large intestine goes into the small intestine. And then when bacteria from the large intestine goes into the small intestine, they massively ferment sugars and starches and fibers, and they get distended and bloated with pretty much everything they eat. That's the common complaint they have. Now, Parkinsonism, brain-gut axis issues, chronic inflammation, anything that destroys the nervous system of the gut can cause small intestinal bacterial overgrowth. It really should be called small intestinal bacteria translocation, or large intestine translocation of bacteria to the small intestine. That's really what it is. And it's a motor plexus issue. Now, there's also hypochlorhydria, lack of hydrochloric acid, that can cause small intestinal bacterial overgrowth, right? Because you have to neutralize acidity in this upper GI before, because there's two things that are preventing bacteria from being in the small intestine. One is the acidity from hydrochloric acid, and the other is from the valve closing. The easiest and treatable forms of SIBO is they just are protein pump inhibitors. They go off that, they get acidity to their gut, and they're fine. Or they have hypochlorhydria, you resolve that, and they're fine. Those are the easy, fixable SIBO ones. The other SIBO ones that are destroyed gut plexus or brain-gut axis issues, you're not gonna do a protocol to treat them. The reoccurrence rate for treatment with these patients that you do, they use antibiotics and prokinetics drugs to get their gut to fire, it's pretty much 100%, 99%. So they have in the conventional models, they'll do a breath test, measure methane, hydrogen, they're elevated, they'll give them antibiotics. The antibiotics will get rid of it, and virtually 100% of them will have to have that treatment again at some point when the bacterial all comes back. So it's a gut plexus issue. So this is the mechanism I wanted to show you, but here's the key things. It's absolutely critical for these patients that have SIBO to not get worse, because when they have this bacterial translocation in the small intestine, it destroys their microvilli, and they can get malabsorption syndromes. And if you see transcellular permeability, besides celiac, you have to think of SIBO. Now, what happens is when bacteria comes into the small intestine and you get exposure to sugars and fibers and compounds that stimulate bacteria to release gases and ferment, they'll release methane, and that'll decrease their motility so they get constipation. But then the bloating and then fermentation causes their valve to open up. Is that a good or bad thing? It's terrible, because now the valve opens up, more bacteria can translocate in. So when you have a SIBO patient that's not compliant to their FODMAP diet, they're going to continually get worse. Because when they eat something that is sugary or starchy and they get distended, that abdominal distension opens up the valve between the small and large intestine, and more bacteria can translocate in. So if you see a person that has malabsorption syndrome issues and transcellular permeability issues, and they're not following a strict FODMAP, you're not going to make much change. This is a continued, ongoing inflammatory destructive process. Now, besides methane, we know that some bacteria produce hydrogen, and if they have overgrowth of those in their small intestine that release hydrogen, hydrogen actually increases motility and they get diarrhea. So that's why you can have either constipation or diarrhea or both with SIBO patients. And then we know that their osmolarity levels can also be changed, and they can have fluid changes in their mineralocorticoid balances, also causing diarrhea. And if they really, really progress into ongoing SIBO, they can get protein deficiencies. Their albumin levels can drop. Their globulin levels can drop. If their albumin levels drop, they can get swelling in their legs because that's involved with osmotic pressure. And they can have changes. If their globulin levels change, the total immunoglobulin count, immune system can shut down and be depressed. If their hemoglobin levels change because of globulin depletion, they can end up with anemias of all kinds. This is like this is malabsorption syndrome. When they get to this point, they're having malabsorption syndrome. The best test is a marker called preglobulin. We're going to talk about that a little later, but preglobulin is a quick test to know they're getting protein malnutrition, malabsorption syndromes. And then the other key thing is that takes place with these patients that have SIBOs, they start to get microvilli destruction, so they get mineral nutrition and micronutrient deficiencies. They get all different types of anemias. Their brush borders get damaged. So they end up, again, with malabsorption syndromes. They have a hard time metabolizing bile salts to unconjugated bile, because remember, bile salts are circulating in the gut. Well, when you have bacterial overgrowth, that whole system is impaired. So then they have issues with making bile. It's not getting the bile salts reabsorbed, so they get malabsorption syndromes. They're not really gallbladder issues, they just don't have enough bile. They can't get the bile recycled back. They can't make enough bile to compensate, and they don't have enough bile to break down fats. They get fat-soluble vitamin deficiencies. They can't break down fat in their stool. The stool floats. You get the smelly, foul stool issues. And then these people that have these bacterial overgrowths, they also end up with production of litholeic acid, which again starts to damage their intestinal lining, and they end up with mechanisms that damage the migrating motor complex, and they continue to progress down this destructive pathway with inflammation and intestinal permeability. And then this is it, that's SIBO. Okay. This diagram, it took me 2 weeks to make. I grew a beard, so I have no, I'm not joking. You guys don't see me in between seminars, but in between seminars, like between now and the autoimmune one, I'll have to get all these slides put together. I'll be in a cave, I'll grow a beard, no one will talk to anyone, I'll be alone, and just put together the stuff, right? So this one took forever, but it was like, what's the main mechanisms? The key thing with SIBO is like everything can go wrong. That's the bottom line. Now, when you see SIBO, so when a patient comes in and says, hey, when I eat, I just get totally distended and bloated, then the key thing to remember with that is that there's something that's caused that. Early Parkinson's, chronic inflammatory destruction, and when we talk about management, they have to follow a strict FODMAP diet. And if they don't, they can get malabsorption syndrome, and that is going to destroy their health. Okay, so that's a big thing. Now, I have some papers and research here with SIBO. I'm going to kind of go past those pretty quickly. You guys can look at those studies on your own, but I just want to point out a few things. The testing you do for these patients is a hydrogen methane test. We'll talk about those when we talk about evaluation. It's pretty good, but not all types of bacteria get measured with this test. So you can have people have SIBO, but the bacteria they have in their small intestine don't release methane and they don't release hydrogen. So sometimes just the fact that they respond to a FODMAP diet is your best clue. And many times you don't even need, some people don't test. They go, let's just do a trial of FODMAP diet and see what's going on. But the FODMAP diet is pretty restrictive, so some patients would rather have the testing first, so that's your own clinical call. And the other key things I just want to highlight with you here, these are all the main mechanisms. Whoops. These are all the main mechanisms that can cause SIBO, just so you know. That's in the literature. I've given you papers for all of these, but this is just a summary chart. So antacids, hypochlorhydria is the easiest form. Neurodegenerative diseases like alpha-synuclein that damages the gut, traumatic brain injury, anything that impacts vagal activity, chronic diabetes, what destroys the enteric, gets neuropathies against the enteric nervous system, and then any ongoing inflammatory autoimmune, and then direct injury to the enteric plexus like with radiation. And then when people have severe immune deficiencies like HIV, things like that, that can cause some issues, and then anatomical changes. And hypothyroid is one too. Hypothyroidism is a key issue with chronic issues, and we'll get to that. It's because your migrating motor complex, your smooth muscles of the gut are activated with thyroid hormones. So some patients, like the best types of SIBO was hypothyroid-induced SIBO or hypochlorhydria-induced SIBO. Those are treatable. The rest is an ongoing issue, unresponsive. So they're always going to follow a FODMAP diet. And people that have SIBO, they're going to always have to do support for enzymes. They're going to always have to worry about leaky gut and support their permeability pathways. They're going to always have to really optimize their GI health. They're going to be prone to food sensitivities, and that's the key issue. Now, let's talk about GI infections really quick. There's some people that have GI infections, and the key thing is biofilm. And the thing I want to point out here is with some patients, you can't fix their you can't get rid of pathogens until you get their immune system healthy. Like, I would still start north to south before you try to do a parasite protocol. Because even with the people that go on to anti-parasitic drugs, many times won't get rid of the parasite. So what you really want to do is like start north to south, make sure they have that pancreatic enzymes, hydrochloric acid, support the permeability to some degrees, to take off the inflammatory load, and then after a few weeks, get in there, get them a little healthier, and then consider supporting their gut. There's a lot of research showing biofilms can be a main reason that some of these antiparasitics don't actually get to the parasite, that you may want to break down biofilm first. So the protocol that we use to normally treat, and there's some studies on biofilm and a paper you guys can look at, but these are key compounds. So most of the stuff they use for antibacterial, antiparasitic, garlic, oregano, all these things can be used for a period of time, let's say 2 to 4 weeks before they try to do an antiparasitic protocol, especially if it failed, to kind of break up things so the drugs can actually get to the bugs and kill them if that's an issue that they have with them. And this might not be the first place you start, but if you see a patient that's had, let's say, a parasitic infection that has causing symptoms and they've gone on either a natural approach or a drug approach to treat parasites and it hasn't worked, you may need to, again, back off, start north to south, fix the gut, calm down inflammation for a few weeks, break some biofilm, and then medication would be the option. That would be the best way to do it, but you definitely want to do that if they don't respond to medication. The other key thing is hypothyroidism, by the way. And with hypothyroidism, this only matters if they're actually hypothyroid, meaning if they're on replacement, these factors are not a problem anymore. So thyroid hormones directly bind to the vagus and to intestinal motor cells and smooth muscle cells of the gut. So if someone is truly hypothyroid, you can get chronic constipation, you can get presentations of SIBO, you get digestive enzyme deficiencies. So if you guys have a chronic GI patient that no one else has worked up or no one has been any recent blood work, just make sure they're not hypothyroid, because you could be wasting all this time and you go, hey, you're hypothyroid. They go on thyroid replacement and within a week, everything's better. Now, some people don't have GI manifestation with hypothyroidism, but some do. So always be aware of that. And these are just some pathways showing you how thyroid hormones bind to direct pathways of the vagal motor complex and to different areas of the gut, smooth muscles. You guys can just review those as long as you understand the concepts. And then I put a really good paper in here for you. It shows you how different diseases impact thyroid hormone absorption, like celiac disease or parasitic disease or motility impairments. So some patients, they don't respond to their thyroid medications. How would you know? Because their TSH would still be high. By the time they figure out what dosage lowers their TSH, it's not a factor, but sometimes like their celiac disease flares up or they get exposed to food and now their TSH is high and they haven't changed their thyroid hormone medication in the past 6 months or past year, and now their hypothyroidism is contributing to a factor why their gut's not responding. So just know in the back of your mind that you have to have thyroid hormone activity to normalize gut function. So even an H. pylori infection can impact thyroid hormone absorption. So these things can change, and if it's going to change TSH, and while they're hypothyroid, you may not be able to make a difference treating their gut. So that's another reason you can have unresponsive patients. And this is just some drug interactions that you may want to look at. And then the last thing here is intestinal hyperperfusion. So I put together a list of studies where this is the main mechanism. There's decreased cardiac output or decreased blood pressure. When there's decreased cardiac output or decreased blood pressure, there's not enough perfusion going into the mesenteric vascular system. Perfusion means pressure, blood flow pressure being pushed into the gut. So low blood pressure, low cardiac output, you don't get enough perfusion to the mesenteric vascular system. Intestinal cell malnutrition, the microvilli just shed away because they're like plants and flowers. They need fuel, they need nutrients to function. And then you can also decrease intrahepatic circulation, decrease transfer to mesenteric lymph nodes, decrease transfer to thoracic. You get loss of immune tolerance because you're not getting these proteins to communicate with T cells and B cells and antibodies throughout the body because that pressure has to take place for these to get in the lymphatic system. And you get a person with chronic GI issues. So I put together a list of papers, everything from intestinal function and chronic heart failure, the heart and the gut studies, some of these studies with liver cirrhosis, some of these studies with chronic kidney disease, that all have this hyperperfusion mechanism and how it leads to chronic GI issues. So just be aware of that. So those types of patients, you're going to basically do what you can. Optimize their enzyme, give them some enzymes, give them some short-chain fatty acids, improve their diet, but they're going to be unresponsive. Okay? So those are the main mechanisms with these conditions. The way you find them is usually from their history. Again, one more time as we finish off here. The key thing with them, they're going to come in eating a diet that's very limited because they have to. Nothing has helped them. They've had it for a very long time. When you hear all those, you should be thinking of these red flags. And then you should go through each one of these one by one and make sure they're not there. And if they're there, you just work with what they have, okay? And we'll get into treatment protocols this afternoon. We'll talk about these conditions again. But just make sure you're aware of these mechanisms that can impact the gut. Okay, let's take a break and then we'll get into working a patient up.